you, MSD, and thank you for Bansi Sabu for inviting me to speak here at Diabetes India. First of all, I have to say, when I was supposed to be doing my fellowship at Loyola University in 1989, as my CV showed, I had not even passed out from medical school, so there's a bit of a mistake out there. So let's go on to glucagon, the missing piece in diabetes management. And, you know, the agenda of this talk is divided into introduction, history, physiology, pathophysiology in diabetes, and the clinical implications of this, and I will try and stick to time. The introduction, now you see this slide is completely in black and white. When I went to medical school and I learned about diabetes, television was black and white, and the pathophysiology of diabetes was black and white. Beta cell failed, and there was insulin resistance, and this led to type 2 diabetes. However, as the years went on, today we have color television, and indeed we have a colorful view of the ominous octet of type 2 diabetes. And indeed what I'm going to focus on is the increased glucagon secretion that we see as one of the pathophysiological defects in type 2 diabetes. And this has been recaptured by Unger's seminal work, and he's published in JCI in 2012, where he describes the changing concepts of diabetes from an insulinocentric thing to a bihormonal to a 2011 publication where he says that lack of insulin directly causes some diabetes abnormalities. Insulin lack also leads to glucagon excess, so which was previously insulin and glucagon existing together. Now we have the glucagon excess, which is leading to decreased AGO, and increased hepatic glycogenolysis, increased hepatic gluconeogenesis, increased ketogenesis, and decreased glycogen synthesis. But this concept of glucagon is not new, and it has been there for a very long time. Indeed, a couple of years after insulin was discovered, there was a publication in Journal of Biological Chemistry by Merlin et al., which showed the first existence of the glucagon, and the name glucagon was derived from a glucose agonist substance. Thereafter, the mechanism of action of glucagon was studied, and as we all know, the alpha cells produce glucagon, which lead to increased hepatic gluconeogenesis, leading to increased glucose, as well as glucose coming from the gut, and the beta cells producing insulin, leading to higher glucose uptake, and thereby mobilizing the glucose from the tissues. The physiology has been described in detail, and I will recapture that for a minute. But first I'll show you a picture of the islet cells, the alpha cells, beta cells, and the F cells and the delta cells, as we know, secreting glucagon, insulin, pancreatic polypeptide, and somatostatin respectively. The islets and the alpha cells, the glucagon is produced by the alpha cells. Alpha cells basically constitute 1% of pancreatic cells and 30% of the islet cells. And they are called alpha cells because of their staining pattern. Indeed, both alpha cells and beta cells come from the same pool genetically, but they differentiate in later life to become alpha and beta cells. And these alpha cells produce hormones called prohormone convertase, which converts the pro-glucagon to glucagon in the pancreas, and GLP-1 and GLP-2 in the brain and in the intestine. Glucagon is regulated by nutrient, neural, and hormonal influences, and as we know, hypoglycemia, a protein meal, amino acids, any form of stress in the form of adrenaline or cortisol, sympathetic and parasympathetic nervous stimulation, and GIP from the gut causes an increased level of glucagon, leading to higher blood sugars, and the inhibitory effects being glucose, leading to a feedback mechanism and lowering the levels of glucagon, carbohydrates, ketones, insulin, somatostatin, and most importantly, the last three, the GLP-1, the amylin, and the leptin, leading to lesser levels of glucagon, reducing blood sugar. And there's a physiological balance between the two. Like we know, for high blood glucose, insulin secretion increases. Similarly, for lower blood sugars, glucagon increases, and this plus-minus effect leads to a homeostasis and a normal level of glucose in the circulation. Now, we see from Unger's seminal work in 1971 that when you give somebody a glucose load, the glucose levels go up. And to compensate the rise of the glucose, the insulin levels go up, and indeed, the glucagon levels go down to try and make sure that the glucose levels stay in balance. And this is what the basic physiology of glucagon release from the alpha cells is. And it is also shown in various studies that when you actually inject glucagon infusion, it increases the amount of hepatic glucose production, and this alpha cells are responsible for this. Thereby, glucagon stimulation of the hepatocytes leads to increased hepatic glucose by the processes of increased glycogenolysis and gluconeogenesis, and reduction in the glycolysis and glycogenesis with higher glucose levels. This is important. This homeostasis is particularly important because we want to maintain a static level of glucose in our circulation, and God's gift is such that, the glucagon producing 10 grams per hour, 4 grams are utilized by the peripheral tissues like liver, skeletal muscle, and adipocytes, and 6 grams are utilized by the brain. And thereby, a stable level, a completely normal level of glucose is maintained in our circulation. So what happens in diabetes? In diabetes, the beta cells, which are profound and much more in number, start to decay. There is a much disorganization and misshaping of the beta cells, and amyloid plaques develop all over the pancreatic over the pancreatic islet cells, which means that the reduction in the number of beta cells is compensated by a hypertrophy of the number of alpha cells in the islet cells. And this leads to excess glucagon production and increased hepatic glucose output, leading to higher glucose, and insufficient insulin with less effective glucose uptake leads to this pathophysiological situation of increased glucose in the peripheral circulation. This is shown in the seminal work by Muller, again in 1970s, just the opposite of the physiology. When you give somebody a carbohydrate meal, in a normal individual, it stays normal because the physiology is working. And in a diabetic, as we know, the blood sugars start to climb with lesser secretion of insulin and higher secretion of glucagon, making this a situation, a milieu, where the glucose levels are completely out of control, leading to the diagnosis of diabetes. Indeed, at diagnosis, there's impaired insulin-mediated glucose disposal and excess glucagon-mediated glucose output, spoiling the complete physiology that was being maintained of a normal glucose level and leading to high blood sugars, the main symptom of type 2 diabetes. So what are the clinical implications of this? The clinical implications of this has led to this glucagonocentric restructuring of diabetes. The insulinocentric view of metabolic homeostasis is incomplete, and glucagon is indeed a key regulator of normal fuel metabolism under the insulin sparacrine guidance and control. And I will show you a rat model where it's very interesting to look at if you look at the upper level of this, you see this is mice who have had beta cell destruction. And as you expect, with beta cell destruction, glucose levels have gone to the 400 and 600 levels. The destruction has been done with streptozocin. Now, if you have a knockout mice where glucagon has been knocked out, you find that the beta cell shows, though the beta cells are not there, blood sugars level completely remain the same. So it is indeed important out here to note from this mice model that even if you do not have insulin, even if you do not have insulin to regulate the blood glucose levels, you actually have glucagon to push it up, and if it is not there, you can actually maintain normal blood sugar levels. This has been utilized in GLP-1 receptor agonists, which actually lead to increased glucose-dependent insulin secretion, increased insulin synthesis, and with the increased somatostatin secretion, this causes a reduced glucose secretion and hepatic glucose output goes down. Not only that, if you look at this seminal work done by Christine Hare and her colleagues, you find that when you're injecting GLP-1 receptor agonists, you find what is important to note is I'll go back one slide. What is interesting to note is when GLP-1 has gone up, you find that glucagon levels go down and insulin goes up. to prove the fact that glucagonostatic and insulinotropic effects, both of these combine together to make the GLP-1 receptors effective in the management of type 2 diabetes. This is also shown in this interesting work. This is a clamp, a hyperglycemic clamp, where you find that the blood sugars are stable at a particular level, and the patients have been infused with either normal saline or they have been infused with GLP-1. And as you can see, the people who've been infused with normal saline have a much higher level of plasma glucagon, whereas when you give them GLP-1, the levels come down a lot lower, indicating that the GLP-1 is actually working on the glucagon axis, reducing the glucagon and thereby reducing the blood glucose levels. And in this GLP-1 infusion study, you find that when you give intravenous GLP-1, insulin levels go up, but what is of more importance is that the glucagon levels come down, leading to a reduction of blood glucose level. So I have proven it to you now, ladies and gentlemen, that when you're infusing both of them at the same time, there is indeed a very good reduction in the blood sugar levels due to the joint effect of reduction of insulin secretion, increase insulin secretion, and the reduction of GLP-1, reduction of glucagon. This is shown in this rather elegant study on sitagliptin, where you see that this group, which was initially being treated with placebo, continues to lower its blood sugar levels and HbA1c when you add on sitagliptin, whereas when you stop the sitagliptin, the HbA1c climbs. Now, why do I show you type 1 data? Because, these people are known to be insulinopenic. So the DPP-4 inhibitors, by working on the GLP-1 axis, is not increasing the amount of insulin secretion, it is actually reducing the glucagon secretion, leading to improved glycemic control, enhancing and showing you a novel methodology of the working of DPP-4 inhibitors and GLP-1 receptor agonists in the management of diabetes by this unique method. Not only that, as I had earlier alluded to, amylin, pramlintide, as you can see, with higher levels of pramlintide lead to lesser levels of glucagon, and as we know, amylin is a drug that is used to treat diabetes. And how does it do it? With inducing postprandial glucagon in the liver, leading to less glucose output and decreased plasma glucose secretion. Now, these are the things that we've always known about, that these drugs like GLP-1 receptor agonists and DPP-4 inhibitors have always shown that they work through the glucagon axis. Now, there's been some publications and some things are coming out which are of interest, because this is showing a novel method of other older drugs or novel newer drugs having to work through this axis. And I'll show you some data with metformin, where it shows that metformin also blocks the adenylate cyclase, and this also leads to glucagon-dependent, reducing glucagon-dependent glucose output from hepatocytes. As of date, we still do not know how metformin works actually in reducing blood sugar. And it is indeed important to see that there is another mechanism that is coming out, that metformin might actually be reducing glucagon secretion and thereby reducing glucose output. The new kid on the block, and as Dr. Ajay Kumar was mentioning in his question a little while ago, that metabolic response to sodium glucose co-transporter inhibition in type 2 diabetes is quite interesting. It lowers fasting glucose, yet in this study with empagliflozin, you find that there's a higher endogenous glucose production with lesser insulin and high glucagon and high GLP-1 response, at least initially. So if you look at these studies quite carefully, if you look that initially, when you first give the first dose, there is actually raised plasma glucagon, leading to the higher endogenous glucose production. But thereafter, as EMPA starts to work and continues to, you find that the plasma glucagon level starts to come down. And though there is increased endogenous glucose production, because the glucagon levels are coming down, and higher GLP-1 receptor action working on the glucagon axis, you find that the blood sugars chronically start to come down. Indeed, in Morovci's study, he kind of suggests that a combination of SGLT inhibition with incretin therapies are anticipate to attenuate the increase in endogenous glucose production and will be synergistic in the treatment of hyperglycemia, as was being alluded to by Dr. Ajay Kumar in the last session when we were talking about SGLT2 inhibitions. So to summarize, glucagon derives from the word glucose agonist. In physiological state, as we know, insulin lowers glucose, and glucagon increases glucose via increased hepatic glucose output with increased gluconeogenesis. This is disordered in type 2 diabetes with destruction of beta cells and augmentation in the number of alpha cells with increased number of glucagon response. Drugs like GLP-1, DPP-4 and pramlintide work through the glucagon axis. As I showed you, that there is not only an increase in insulin secretion, there is the added synergistic effect of reduction of glucagon, which leads to this efficacy of the drugs GLP-1 receptor agonists and DPP-4 inhibitors. And now, with glucagon coming so much into the picture, there seems to be an evolving role of this glucagon pathway, because now even older drugs like metformin and newer drugs like SGLT2 inhibitors seem to be having some effect on this axis, making them worthwhile glucose-lowering agents. Thank you very much for your patience.